Good afternoon to everyone. So after some interesting cases on OCD, OCTA and ENDOF, let's go through an interesting case that I encountered in my OPD, a curious case of fever and retinitis. So this was a 24-year male patient who complained of diminution of vision in both eyes, left eye more than right eye for 15 days, and the only positive history was history of fever with severe headache 1 month ago. So on examination, vision in the right eye was 6/6 and left eye was counting finger of half meter. So this was the fundus examination of the right eye. It showed multiple cotton wool spots in the entire peripapillary area, as you can see, and in the left eye they were extending onto the arcades, obviously indicating an ischemic insult. So this was the OCT, which showed intraretinal fluid spaces along with hyperreflected spots, as you can see. And the left eye, the picture was more grotesque with retinal inflammation thickening, as well as intraretinal fluid cystic spaces and marked subretinal fluid. So this was the FFA, which showed hyperfluorescence along the retinal vessels and the peripapillary area. So going on to the investigations, the BP was normal, the sugar was also all right. The Vidal test showed S typhi A, which was reactive, and the other tests which were all non-reactive. So made a diagnosis of post-fever retinitis secondary to typhoid. The patient was started on systemic steroids, starting with 50 milligram per day in weekly tapering doses, and oral ciprofloxacin was also added, 500 milligrams BD for 5 days. Patient was reviewed after 15 days, and to my disappointment, the vision in the right eye had dropped to 6/18, and left eye was more or less the same. It was a counting finger of 4 meters from counting finger of half meters. So this was 15 days after starting the systemic steroids. The cotton wool spots such as retinitis lesions in the peripapillary area, and there was in the left eye there was a macular fan which suggested resolving macular edema. And this was the OCT picture. There was thickening of the inner retina and after shadowing with minimal subretinal fluid. So the fluid had absorbed, but the peripapillary area was absolutely choked. And this was the OCT image of the left eye. On FFA, you can see that the hyperfluorescence had increased, and there was CNP areas also along the arcades and the peripapillary area. So at this point, I decided to give anti-VEGF injections, and I started with ranibizumab given in the left eye, followed by right eye for a week, after a week, or between both the eyes. And this was the fundus examination of 15 days after the first injection. You can see that this macular hard exudates are there, showing that the lesions are resolving, but the cotton wool spots remained more or less as they were. And this is 15 days after the first injection in the right eye. So this is both the eyes put together. So at the end of the whole thing, the edema had decreased, but the retinitis, the cotton wool spots had also marginally reduced, but you can see a lot of wrinkling in the inner retinal layers as well as the outer retinal layers, and some amount of retinitis which was persisting. And this was the OCT pictures of the left eye, and you can see at the end the fluid had resolved and the hyperreflected spots had also decreased. This is the OCTA images that I had taken. So why I chose this case was that normally post-fever retinitis, especially typhoid retinitis, has a very good prognosis, but in my case things were a little different. Post-fever retinitis is an infectious or a para-infectious uveitic entity caused by bacterial or viral agents. It usually occurs the 3rd week after the onset of typhoid fever, and this is referred to as week of complications. Typhoid retinitis may occur secondary to direct invasion of Salmonella typhi, bacillus, or immune-mediated reaction. In most cases, fundus lesions resolve, leaving a pigment epithelial changes and foveal thinning. So though there was no endophthalmitis secondary to typhoid, the vision was very poor in this case, and more or less I attribute it to probably the retinitis lesions sitting directly on the papillomacular bundle and choking the entire papillomacular bundle. Thank you so much for your kind attention.
case for this post-typhoid retinitis? Because I haven't come across this. Probably the horse can add to it.
Sir, there are only a few reports for typhoid retinitis.
Picture is like this.
Picture is like this. But the only thing is, it goes like a bell's curve. Whether you treat or not, post-fever retinitis will increase and then decrease on its own.
Yes, yes, that is exactly what I was trying to say, that whether you know, because there were hyperreflected spots on octa, that is why I initially thought of giving systemic steroids, and I held on to the anti-VEGF agents. But if you had noticed, the edema was increasing and vision was quite poor, and in the right eye also the vision was decreasing. So, and it was a young patient, so that is why I thought I should be more aggressive and do anti-VEGF treatment also along with the systemic steroids.
But anti-VEGFs in post-fever retinitis have not
Because
been.
I too don't agree with the role of anti-VEGF in an inflammatory disease. If at all it's an anti-inflammatory disease.
That is why in the first case scenario I didn't start the anti-VEGFs, but considering this case, and especially the papillomacular bundle was so severely affected, at the end, if I see retrospectively, I don't know whether the anti-VEGF really worked or was it the natural resolving history of the patient. But my case did not show a very good prognosis than what we expect out of post-fever retinitis, especially the typhoid retinitis.
Other viral infections also to be considered.
Yes, yes.
That
Is
would
there
be
a
the
role
reason
of
for-
post-viral, oral antiviral?
Yes, sir. And doxycycline can also be tried.
Because picture like this I saw in Pusch's retinopathy or ARN, herpes-related
Herpes.
acute retinal
So
necrosis.
Salmonella
Something
typhi
like
was positive, and then if there is one positive history, we go on to that.
Did the patient complete the course of antibiotic for typhoid?
Yes, yes. The patient had already had already been referred to me by a physician, and he had already completed the course.
Thank you.
Thank you.
सर जैसे करें इसका HIV प्रोफाइल भी करा लेना चाहिए ऐसे केसेस जो डाउटफुल सर
I think sir मैंने कराया था.
हाँ जैसे मैसेज करो बिल्कुल सही कहा डेंगू में जनरली ब्लीडिंग होना जरूरी मतलब देखा है मैंने क्या होता है सिर्फ कॉटन स्पॉट्स रेयर देखे मैंने
पोस्ट चिकनगुनिया भी पोस्ट
ब्लीडिंग
चिकन
थोड़ा सा ज्यादा होता है
प्लेटलेट नीचे किया
प्लेटलेट के लिए गुड केस
There are a lot of other investigations which I have done. I will list it only.
ओके